And good afternoon. I'm Joseph Kopser, and we are live on another show, episode, wherever you want to call this, of Catalyst Talks. It is the 57th day of March 2020, and I'm joined by, I think, four-time repeat guests on the show, Doctors David and Beth Hawse, who I get a lot of feedback every Saturday when I have them on because they're answering your questions. They're being very direct. There's not a lot of let's just say spin or sarcasm. Beth, is that the word we're talking about this week?
Yeah,
sarcasm.
Word of the week.
Very straightforward. So with that, I want to just jump right into it because we're here to talk about how you adapt to a changing world. I want to talk about medical data, some of the tests that have come out this week and what they mean. I'd love to dip our toe just a little bit into what you think the future of the workplace looks like in medicine now that we've exposed so many of these issues. And with that, where do you all want to talk first? What's the most important thing that people need to know?
Don't take Lysol internally.
Okay. Good point. In fact, I'm glad you mentioned that. I've even got
now, to be serious about this, the thing is, the president is not a doctor, and I understand the president is sitting there and he's spitballing and trying to think of ideas, and and the problem is that people listen to him and take what he says seriously, even if he says it's sarcastic. And I don't know that that's a platform to spitball. And so obviously, disinfectants are dangerous. If you take them internally in any way, you could die from it. Ultraviolet light does cause sunburns. And if you put ultraviolet light internally inside your lungs, it sounds like a good way to get a burn of your lungs, which certainly would not help inflamed lungs. No. So we can leave it at that.
No.
Okay, we've left it at that, so we're very clear. What other events of the week do you think are noteworthy that we need to be talking about?
I think the antibody testing, I think that's going to be the big thing, and maybe I'm just a little selfish thinking in my own world, but our lab that we use, that we send our patients to, is going to be able to run COVID antibody testing on Monday. And I called the lab on Friday to try to get the sensitivity and specificity. And we talked about that last time. So to see how accurate the test is, which they've not gotten back to me. But when I read the little owner's manual, so to speak, the little PDF that they send with all the technical, like a technical bulletin on the test, it says, well, there's a lot of people that react to these 3 or 4 other types of coronavirus that are going to get a positive on this test. Well, we see those 3 or 4 other types of coronavirus all the time. And
again, it's important to tell the audience, coronavirus is not new. COVID-19 is one type and is new. Can you expand on that?
Right. So regular coronavirus is just cold. It's one of the common cold viruses. And so we see kids all the time that we test to be sure they're not having flu because they have a fever and cough, that actually just have regular American run-of-the-mill coronavirus. And so I talked before we started, David, you had that in December because David had a fever. And so we were like, well, do you have the flu? Do you need to stay home and not infect the infants in our office? So we tested him and he had some random, coronavirus, not obviously COVID-19. So that's my concern with those tests, is lots of people are going to test positive. And my concern is if they don't understand medical data, they're going to think, oh, I can.
Which day? The person they or their healthcare provider?
Well, the person may, and sometimes their healthcare provider may, if you don't read the fine print. If you're a medical provider and there are multiple different labs that have antibody tests, some are better than others, and you need to know as a medical provider what the sensitivity and specificity of the test you're running show, exactly what data are you getting from the test. And so, but what I don't want is people out not washing their hands, not socially distancing, thinking they're immune and then getting really ill.
I think the other thing is there was a study that came out this week that estimated, they took a random sampling in New York trying to make an estimate of how many people were actually infected by using antibody tests. And they come to the conclusion that maybe 20% of New Yorkers have been infected. Now, frankly, if that is true, that is probably a good thing in that it changes the mortality rates. If 20% of the people have had it and you have the number just over 10,000 deaths, that's a much lower mortality rate. I don't
Right.
have the exact numbers in front of me. But the problem is, if you say 20% of the people had it, but it turns out, and it would not surprise me that if 20% of Americans get coronavirus in a 12-month period.
And do you mean specifically COVID-19?
No.
Just any kind of coronavirus.
20% of Americans get infected with coronavirus in any given year. I don't know what that number is, but that would not be an outlandish number, I don't think.
Right.
And so the thing is, if the test is actually getting those people and saying 20% of the people, and then those people are then, cleared to work by their governors, by their employers to go in, you're just, it's a ticking time bomb to restart this again.
Right.
Yeah.
Which, if you look at the national numbers and you look at Kentucky's numbers, we've kind of flattened out in new cases, which is a great thing.
But this is why WHO came out, the World Health Organization came out today and said there's not going to be such a thing anytime soon like an immunity passport where you're immune, you're going to be able to get on a plane, it's safe for you to travel. Right. The tests just aren't that good yet.
Well, can I just clarify in what I understood from reading that same news story or similar news story? Is it that they found no evidence or no proof yet? And right. There is a difference there, right?
Correct.
Right. We just can't say yet.
Okay.
It can change, but it doesn't mean, what they're saying is if you have antibodies, all it means is you have antibodies we can measure. We don't know that those are protective. We don't know that they're not protective. Right. We don't know either.
And you have to keep in mind, a few things. Number one, you have to keep in mind that people get, over a 5 or 10 year period, people may get a similar cold, the same virus multiple times. Right. So, there are viruses out there that you don't get what they call neutralizing antibodies to. At least they called it that 20 years ago. And
immunology has probably changed from last week to this week. Yes, it changes every week.
But there are things that you can get infected with that you don't develop good immunity to. And then the other thing that I just tell, I've been telling people just to think about, you have to realize that we have been working since for almost 40 years now, trying to figure out a vaccine for HIV.
Yeah.
Don't have one.
Yeah.
And, and so I'm not saying there can't be a vaccine to this. I just think people need to be thinking about how they're going to modify their daily lives to be able to accommodate, to live in a world that, live in a world that wants to travel widely, people can, for businesses, people moving across the country, moving from country to country, to maintain the businesses, yet live in a situation with infectious disease that we can't control. Because right now that's where we are. I don't know if that's where we're going to be in a year, but today that's where we are.
Well, let's talk about that idea, this future of work. Because if you go to Google search trends, what people are trying to wrap their brain around right now, and this was happening before COVID-19, but it's more accelerated by this phenomenon that you just described. In terms of the medical industry, and not just your peers, but people going in to see their care provider, what do you think the future of work looks like in the 6 or 12-month horizon? What's going to change? A typical trip to the doctor, a typical trip to the dentist. What does that look like?
I think
that's going to be hard.
Yeah,
the poor dentists.
The dentists are really in a conundrum, because you can imagine, being that close in people's faces, using drills that are aerosolizing saliva up into people's faces. That's going to be a trick. As far as healthcare, or as far as non-dentistry medicine, I do think there's going to be a lot more telemedicine, and that's not ever going to go away. I was talking to a friend of mine today about this, and he's an interventional cardiologist, and says probably 30 to 40% of his clinic will be telemedicine moving forward.
Yeah.
The other thing is, there was an article yesterday in the Herald Leader, which is the Lexington paper, that talked about the university, which is the largest hospital in the city, hospital system in the city, has had a 50% decrease in their ER visits. And they're out there saying, don't forget to go to the ER if you're really sick, which 100%, if you're really sick, you need to go to the emergency room. But, there are a lot of people that go to the emergency room for ear pain at 2:00 in the morning, and for, they get a fever and have a fever, on a Saturday, and they show up in the emergency room. And I think it's not only, it's not going to be driven. I don't think it's going to be driven by healthcare providers as much as it's going to be driven by patients who look at it and say, maybe I don't need to go to the emergency room. Maybe I don't need to go to the doctor. Maybe I should give this 2 or 3 days.
And there are multiple factors to that. So one of them, heart attacks, more people have heart attacks in the winter when it's flu season. So many people, the straw that breaks the camel's back with that is they get a respiratory illness. And because we've all stayed at home and the kids are at home, there's just not a lot of respiratory illness. So maybe people aren't going because they're not sick. The other thing I've told David, and this is, I'm sure, true for lots of people, I keep saying, well, other than many people are dying of coronavirus and that we're not making any money, I have not been so relaxed in my life.
As a healthcare provider.
Yeah, oh yeah.
Well, no, as an American.
But
I'm not driving 3 kids to 3 different practices after we've worked
you're speaking about the stress level.
The stress level of Americans, and I know I don't mean to minimize people's stress over money or stress over getting coronavirus, but I'm saying I'm seeing people out taking walks with their families, being out in the sunshine, all those things your doctor tells you when you have anxiety that make it better. Slowing down, not overscheduling, cooking at home. So I think some of this is fear of going to the ER. I think some of it is people aren't having strokes because their blood pressure is not 200 over 100 because they're running at both ends and they're having some healthier lifestyle behavior. I think it's a combination. So I hope that we can preserve that. I mean, that's hard because the American work ethic is to work and work and work and work. But it does make you realize sometimes we do all this work and why are we doing it, or why are we not teleconferencing, or why am I not doing more telemedicine? Why am I torturing my patients and myself, making us run to one more thing? Why? It doesn't make a change in how
I think similarly, the education industry is realizing that, they took a model that was built on an agrarian society calendar, i.e. school 9 months of the year and then off for 2.5 during the summer. That's being disrupted because a lot of schools may have to go into the summer for school. Right. And then on the flip side, you also have the industrial age method of packing everyone into a classroom, desk, everyone's getting the same instruction. And then you further add or complicate that, the fact that you have so many working parents now, dual income or working moms that are putting their kids in childcare when they go off to work, that they counted on either childcare or school to be there. So how do you see that impacting your patients and what they're talking about school age kids or even your own kids, since you guys are parents as well?
Well, ours are, thank God, old enough to stay home by themselves, because I would hate to be when we had 3 people under 5 in my house. They'll ever
be able safely to stay at home together, but that's
maybe not, but for different reasons. But I remember when the kids were little. I mean, it was horrible. Like if I was sick and couldn't go to work, or they were sick and needed to stay home, and you had to have plan A, B, C, and D of what was going to happen. And never did I have a plan that lasted for 2 or 3 months of them being home. So I really feel for people because it's really difficult, and the daycares are closed and the schools are closed. So I don't have an answer for that, but it's not going to be a simple answer.
Well, let's talk on that subject of no simple answers here. I'm trying to keep it under the 20-minute mark, but I want to squeeze this in if I can, which is, are your peers in the medical industry that you're talking to, are they discussing any more than they may have in the past about changing the way we align incentives in the medical industry, the business side of it, who the bill payer is, what the whole chain of custody or responsibility, what's happening there?
Oh, I don't know.
I think increasingly this puts pressure on small groups like we own, who aren't, you see this in the state as far as getting PPE,
PPE?
PPE, so personal protective. So N95 masks and that sort of thing.
Yep.
In our practice, we don't need N95 masks 6 months ago. And so we didn't order an N95 mask. So then when this happens, our provider, our medical supply provider tells us that we're not allotted any N95 masks because we've never ordered them.
Like, well,
so
there was
they have
not
no
a pandemic
intention.
before.
So it's not like, even though they're providing it to hospital
Right.
systems, we can't go buy it from them,
Right.
which is problematic as far as opening up small practices. So I think that's one thing.
Yeah.
I think the other thing that you're going to see happen, one thing that did not occur, there was a bailout for for people
for adult physicians,
for people who take care of people on Medicare. If you take Medicare, in the first bill where each physician practice was given some money, the AAP lobbied for one for pediatrics to happen in this one, which didn't happen.
No.
And so so the problem with that is you're going to have a lot of businesses.
I mean, I'm just making that obvious.
Yeah.
So we don't take Medicare. We have no one over 65.
There are going to be a lot of businesses that are pediatric practices that are going to struggle to be able to keep the doors open.
Yeah, we're like grocery stores. Our margin is not, our margin's thin.
And so, there's conversations. Do insurance companies start buying physicians' practices? So you've thought about this, like, hospital systems like UK go out and buy practices, or Baptist Health, or I'm sure in Austin, you all have all over the place. But now our insurance companies, in order to be able to provide care, a panel of physicians, are they going to have to get into providing care? I personally think this all goes back to, once again, we have to realize how everyone's health affects not only them, but everyone else around them.
Yep.
And I think this is going to put increasing pressure. I'll just briefly bring this issue up. The whole concept of Medicaid or Medicare for all. The thing is, if they simply allowed Medicare to quote insurances to businesses, their overhead is lower than that of other companies, that of Anthem, that of United, that of all these other places. And so we could get to a single payer system by allowing Medicare to compete. And that would have two effects. Number one, it would bring, like our practice, we have young employees. It would bring premiums into the Medicare system to be able to pay for older people whose health wasn't as good. Two, we would be highly likely that we would go in that direction because, frankly, the cost. And so for anyone who says that they get to choose their own physician, well, really, we have a meeting once a year where we, as owners of our practice, choose our insurance, and we're making that choice based on for our employees. And based on the finances of being able to provide insurance.
Yeah, people don't understand that. The provider network they have through their insurance at their job was chosen for them by whoever their bosses are.
Correct. So,
but the thing is if you have some competition, it should make everybody better, right? Anthem and United and Humana can't continue to charge they could not compete. So they would have to cut some of their overhead somewhere. So that might be a good thing for everybody.
But you have to realize
it just can't.
But at its core,
work like it is.
At its core, you have to realize it's not your next door neighbor. It is the person who is the busboy in the restaurant that you go to. If he is uninsured and he has to go to work sick.
5 o'clock.
5 o'clock.
5 o'clock.
If he has to go to work and he comes to work sick.
Totally dark, actually.
That's going to affect you.
Yeah.
And
because they spread whatever they might have.
Correct.
And that is actually probably the perfect way to button this one up today, because I know the governor of Kentucky, is he still doing his daily
5 o'clock every day?
5 o'clock. All right. Well, I'm going to let you all go so that you can be there. Any last thing, David or Beth, that you want to share that I didn't ask?
Nope.
No, I think that was a good one.
Short, sweet, to the point. I'll move this over to LinkedIn. If there's other things that people think of, by all means, please send it over there. Dave and Beth, once again, thanks for being a part of our discussion. Take care. So thanks again for tuning in to another Catalyst Talks. The whole point of this series is to understand all the basic assumptions we have that we've used in the past to make decisions, and now how they're changing and what that has as far as impact on the future of work. We are certainly in need of leadership and strategy in this changing world. It's folks like David and Beth and all the other subject matter experts we've talked to in these 40 plus interviews. You can go back and find any of them on the Grayline website and or specifically the Grayline YouTube page. And then if you have any topics that you want to have discussed or people you'd like to see on, by all means, reach out to me in this thread or over at josephkopser.com or at LinkedIn. I'm Joseph Kopser. Thanks for tuning in. Take care.